Alright guys, so today we're going to be talking about cerebrovascular accident, also known as stroke, and this is chapter 15 of your Sullivan book. Before we start with this chapter, I need you to be very comfortable being able to differentiate between the arteries that supply the blood flow to the brain, as well as what those arteries supply, what lobe of the brain does that artery supply. And the reason being is because knowing the different arteries and what these different arteries supply, when you are doing a chart review for your patient and you see that the patient had a right MCA, middle cerebral artery stroke, you know that the middle cerebral artery supplies lobe X, Y, and Z. And further going forward, you need to know what these lobes are responsible for. So you need to know that if an artery is affecting the cerebellum, then the cerebellum is responsible for balance, for coordination, for posture. So based off of that, you can kind of already know before actually even seeing the patient what this patient is going to present with as far as what impairments and what deficits the patient has. Just based off of knowing the artery that was affected, the lobe that was affected, and the function of that lobe, you will be able to tell. So I am going to go through all of those things throughout the lecture, but this is something that you need to know for your own practice in the future, as well as before getting to practice in the future, your board examination. And knowing these arteries and what they supply and what the lobes are responsible for is just going to make it that much easier for you to differentiate between a middle cerebral artery stroke and a posterior cerebral artery stroke. So please get very comfortable with that. Furthermore, we're going to talk a little bit about what the CDC, the Centers for Disease Control, talk about when they are mentioning stroke prevention and health promotion. You can further read some more on page 595, but some of the risk factors that we're going to be talking about when it comes to stroke are obviously blood pressure, cholesterol, diabetes, smoking, obesity, stress. Sometimes they say that stress or anxiety and depression may lead to stroke. Some birth control pills are also considered to be a factor in the cause of stroke, and sleep apnea as well. So some prevention strategies continued, obviously, with all of those risk factors that we talked about in the prior slide. It is very important to do as much as we can on our part to prevent this from happening to us or our family members or our loved ones or our friends. So obviously eating healthy, limiting alcohol intake is very important. Getting regular exercise, so some type of physical activity. The CDC recommends about 2.5 hours of moderate exercise a week. So that's roughly around 30 minutes a day, 5 days a week. So 2.5 hours of moderate exercise is what we're looking for our patients, ourselves, our families, to be able to comply with in order to prevent stroke from happening. Lower cholesterol, the CDC in your book states that the cholesterol has to be below 200. So that's the number that you want to keep it below to keep the prevention, the risk factor low. Managing your diabetes is very important. Stopping smoking, extremely, extremely important. And sometimes being on an aspirin regimen may reduce the risk of stroke, but this has to be ordered by the doctor. This cannot be ordered by the physical therapist. It cannot be ordered by the physical therapist assistant. This aspirin regimen has to come directly from the doctor. Just make sure also that you know when I say stop smoking, Nowadays, there's also vaping that we have to think about. So that's one of the main items that hasn't made it into the textbooks yet, but it's actually just as bad as smoking. So definitely a prevention strategy would be to stop vaping. It's very important to know the modifiable risk behaviors. These are some of these behaviors, some of these unhealthy behaviors that we can change. So if you can imagine some of the ones that I just went over, obviously, can we manage or change smoking? Absolutely. Can we get healthier by exercising? Yes. So those are some examples of modifiable risk behaviors. And the four that are on here are lack of exercise or physical activity, poor nutrition, so eating healthy, very, very important, tobacco use, and I will add vaping to that as well, or drinking too much alcohol are one of the four major ones that we can change if we wanted to, if we really wanted to. So, textbook definition of a cerebral vascular accident or stroke is an acute onset of neurological signs, which we're going to be talking about, signs and symptoms, secondary to a disturbance in blood supply. So, CVA is that sudden loss of neurological function, which is caused by an interruption in the blood flow to the brain. This interruption is going to produce signs and symptoms that are of neurological origin because it's blood flow being restricted to the brain for a period of time. In order for this to be considered a cerebral vascular accident, the signs and symptoms of neurological deficits have to be present for 24 hours or more. And we will be talking a little bit later on in the lecture about a TIA or a transient ischemic attack. This is sometimes termed as a mini stroke because the neurological deficits, the signs and symptoms, are not going past those 24 hours or more. So I will talk a little bit more later on in the lecture about transient ischemic attacks, but please know that for it to be classified as a cerebral vascular accident or a stroke, those neurological deficits have to be present for 24 hours or more. This occlusion, this interruption of blood flow to the brain causes either a temporary or sometimes a permanent loss of function due to that blood not getting to those tissues of the brain. So motor deficits are characterized by either paralysis, which is hemiplegia, or weakness, which is known as hemiparesis, generally on the side of the body that is opposite the lesion. So a stroke, it is important to know that a stroke is named for the side of the brain that it is affecting. So if I say my patient has a right CVA, that means that the right part of the brain is the blood flow is interrupted. Therefore, the right side of the brain controls the left side of the body. So my patient with a right CVA is going to have left hemiplegia or left hemiparesis. My patient with a left CVA is going to have right hemiparesis or right hemiplegia. So for the sake of this lecture, I want you to take a ribbon, I want you to take a TheraBand, I want you to take anything that you can wrap around your right leg because we are going to mimic that you had a left CVA, therefore the left side of your body, therefore the right side of your body is affected. So you're going to put that ribbon or that scarf around your leg, just so that you know that we are talking about a left CVA that affected the right side of your body. So this slide right here is crucial because the faster we get the patient medical treatment, the more of a positive outcome the patient will or may have. So this is a quote from the CDC. Time lost is brain lost. So the more time the patient goes without getting that medical treatment, the more area of ischemia is going to be is the more ischemia is going to happen. So every single minute counts. And these are some of the signs and symptoms of stroke. There's going to be sudden numbness or weakness in the face, the arm, or the leg, especially on one side of the body. There's going to be sudden confusion, trouble speaking, or difficulty understanding speech. There's going to be sudden trouble seeing in one or both eyes. There's going to be sudden trouble walking, dizziness, loss of balance, or lack of coordination. There's going to be a sudden severe headache with no known cause. So how do we know? How do we find out if my patient is actually shivering because they're cold? That's just an example. Versus my patient's is unable to lift their arms up and has drooping on one side of their face. So there is this very important mnemonic that you have to know, and it's called FAST. And I believe you have covered this before in pathophysiology. So FAST stands for face, arms, speech, and time. So face, you want to ask the person to smile, and we are looking for symmetry. We're looking for symmetry on both sides. Does one side of the face droop? The patient may be having a stroke. Let's continue on with the A in FAST. So arms, you want to ask the person to raise both arms, and if the patient or the person cannot lift, let's say, the left arm, and the right arm is going up as high as possible, and the patient doesn't have anything going on with the shoulder that's limiting the patient musculoskeletally wise, then this is another sign of stroke. That the patient cannot bring those arms together up at the same level. Then we move on to speech. So you ask the person to repeat a simple phrase. A simple phrase that is used, the sky is blue. So you ask the patient to say the sky is blue, and the speech is slurred or it sounds a little off from the norm of what that patient is supposed to sound like. So again, the speech is being affected right now. And the last one is time. And if you see any of these signs, any whatsoever, it's not that you're going to get into the car and drive that patient to the hospital, but you do have to call 911 right away, because when we go over the treatment options for strokes, time is of the essence. They have to get medical attention as quickly as possible so that we can provide that patient the best outcome possible. So there are two main mechanisms that cause a stroke or cerebrovascular accident. We have hemorrhagic strokes, which occur when a blood vessel bursts within the brain. And then we have ischemic strokes, which occur when a blood clot blocks the flow of blood in an artery within the brain. So out of the two, the worst one is obviously going to be the hemorrhagic stroke, because that blood vessel is going to burst. An ischemic stroke is bad as well, but if you're comparing the two, definitely the more lethal one is going to be the hemorrhagic strokes. And we're going to be talking about both of these. So an ischemic stroke is, again, a result of a thrombus. It can be secondary to atherosclerosis, that is the most common, or it can be an embolism from a cardiac condition. 83 to 85 are this type of strokes according to the American Stroke Association and the National Stroke Association. Documented strokes for the majority, the most part, 83 to 85% are ischemic strokes. This, again, is a result of a lack of blood flow that is going to deprive the brain from oxygen and other nutrients, Therefore, that is going to give you a cerebral infarct, and it is going to equal in tissue death in the area that is being occluded. So the viable tissue around the infarct is called the ischemic penumbra. The infarct can spread to this viable tissue due to chemical reactions that are happening. This is why it's extremely, extremely important to know the signs and symptoms of a stroke so that we can act fast. In a rehab hospital, we have stroke alerts. So the whole hospital, you hear over the loudspeaker whenever there is a stroke alert. So they just say stroke alert room 505. And that means that the therapist that was working with that patient saw some of these symptoms and immediately called a code, a stroke alert. Okay, sometimes they call a code blue, depending on where you're working. As far as in the facility that you're working, they handle things a little bit different. All right, so now that we have learned a little bit about what happens with an ischemic stroke, now we are going to discuss 3 interventions that are done for ischemic strokes. So the TPA, or tissue plasminogen activator, is an activase that dissolves clots. But this medication has to be given within 3 hours of onset. So it is very important that we are very familiar and comfortable with looking at the signs of a stroke, because this is where fast comes into play. That face, that arm, the speech, and the time. So this drug has to be given during that time frame in order for that to be effective in dissolving the clot. Then we also have the Mercy Retriever, which are for those patients that don't respond to the TPA, the tissue plasminogen activator, or those patients that are coming for treatment beyond that 3 hour window. This is through the mechanical removal using a catheter. It's generally threaded up the leg, and then it goes into the artery and or the vein, and it pinches and pulls and threads out that clot. And in the next slide, I'm going to show you a picture of how that is done, just an illustration. Then we have the penumbra system, which is used for within 8 hours of onset. And this is once again a catheter that breaks the clot up and then vacuums it out. So they insert a catheter to dissolve the clot first. It's not like pulling it out fully. It just goes in there, and then it dissolves it and it vacuums it out. So it kind of gives you these 3 medical interventions in the order of when they are used. So the TPA, the tissue plasminogen activator, is within those 3 hours of onset, and if it's past those 3 hours, then typically the patient will not respond. The drug will not be able to dissolve the clot. The Mercy Retriever we have for those who are beyond those 3 hours, and it is once again a catheter that's inserted, and it pinches and pulls that clot out. And then we have the Penumbra system, which is within 8 hours of onset, and it is pretty much a catheter that is inserted in there. It dissolves that clot, it breaks it up, and then it vacuums it out. So please be very familiar with all 3 of these medical interventions and know that they are used solely for ischemic strokes. So here in the picture on the left-hand corner, we have the Mercy Retriever. Actually, they're both the Mercy Retriever, which is the second medical intervention that I talked about in the previous slide. And this is the little coil that they put in there, and then they pull that clot out. And then this is just a picture of a clot that was pulled out using that Mercy retriever. Okay, so following stroke, as you know, time is of the essence. Time is very, very important. Following stroke onset, the at-risk brain regions are the ones that are going to be in green. So they could be revived with prompt treatment. So remember in prior slides when I said that the ischemic penumbra is the area of viable tissue, meaning the area that is good. Dependent upon how much time goes by, that area starts becoming red. As you see here in 10 minutes, the ischemic penumbra is much larger than the area of ischemia here. Now it goes into an hour, then that ischemic penumbra becomes smaller because now there's a lack of blood flow in further into that ischemic penumbra. Moving on to 3 hours, you see that pretty much the entire ischemic penumbra is now ischemic. And 6 hours, obviously there has been so much ischemia that it has covered the entire area. There is no area that we can call the ischemic penumbra because more brain tissue has died as the time has gone from 10 minutes all the way to 6 hours. So just to read what's on the slide, some brain regions in red are already irreversibly lost, and as more time elapses, more brain tissue is going to die, which I cannot emphasize enough the urgency of knowing the signs of a stroke in order for that person to get as urgent treatment as possible, because the sooner that the patient gets a treatment, the percentage of disability may go down dependent upon how soon that patient gets treated. So just know, obviously, a 10-minute treatment will limit the disability to not that extensive. Then as the time goes on, the disability is going to go from moderate, and then it's going to go to severe disability. The second type of stroke is a hemorrhagic stroke. A hemorrhagic stroke is abnormal bleeding into the extravascular areas of the brain secondary to a ruptured aneurysm or a trauma. It causes sudden and severe bleeding that can result in death due to that intracranial pressure with adjacent cerebral compression. So all of that blood flow that should not be there is now compressing that area, therefore it's increasing the intracranial pressure. It is extremely important for you to know normal intracranial pressure is between 4 and 15 millimeters of mercury. Anything above 18 to 20 millimeters of mercury is going to be very dangerous. So just to give you a little example, obviously you know that the skull encapsulates the brain, and the brain along with that intracranial fluid is going to help that brain kind of move in that skull, right? So intracranial pressure has to be 4 to 15 millimeters of mercury. Now, patient suffers a hemorrhagic stroke, and that blood now starts invading that area where the brain is freely moving without having any issues whatsoever. This is going to create less room for the brain to flow in the skull. Therefore, it's going to increase that cerebral compression because of that increase in that intracranial pressure. Please know the 3 types of hemorrhagic stroke are intracerebral stroke, subarachnoid, and AVM, which is an arteriovenous malformation, which is a congenital type of stroke. And there are some pictures in the upcoming slide. So the three types of hemorrhagic stroke are intracerebral hemorrhagic strokes, which is secondary to rupturing of that cerebral vessel. Generally, it is from chronic high blood pressure, aging, or weakness from atherosclerosis, which is that plaque formation that deposits into the arterial walls and leads to the progressive narrowing of the blood vessels. Then we have the subarachnoid hemorrhagic stroke, which is typically where that bleeding into that subarachnoid space, typically from the saccular or berry aneurysms, which 90% are congenital. And saccular or berry is just a shape of the aneurysms, as you'll see a few slides down the presentation. Then we have the arteriovenous malformation, or AVM, which is a congenital defect that can result in stroke. It's characterized by a tangle or bunching up of abnormal arteries and veins without a capillary system. A lot of times when the arteriovenous malformation strokes happen, the person is born with it and all of a sudden they have that stroke and die, and they did not know that they had this arteriovenous malformation. In order to manage these type of strokes medically, there are two forms of medical management, and the first one being an aneurysm clipping, which is where the neurosurgeon applies a tiny clip across the neck of the aneurysm in order to stop or to prevent an aneurysm from bleeding and further bursting, causing bleeding into and increasing intracranial pressure. So they just put a clip on it and to prevent it from getting larger and eventually bursting. The second treatment is an endovascular treatment, in which they use a catheter um, in the aneurysm to prevent the blood from entering. So they just use some coil or some reel into the aneurysm to fill it up with that coil and prevent blood from entering and making it larger. So you're going to see a couple pictures down the line where we're going to see both treatments. Here in this picture, we have, on this side, we have an intracerebral hemorrhage stroke secondary to weakness. So in this area, we have weakened tissue. It could be, like I said, from one of the ones that I mentioned. It could be due to aging, but it can more likely be due to atherosclerosis. So eventually, that artery will burst and begin to fill up with blood. So here on the right side, you see the blood starting to pool in this area where it says blood begins to fill the space inside the brain. So this would definitely be probably an intracerebral hemorrhagic stroke, the first one that we have talked about. Then we have the second one we talked about, which was the subarachnoid hemorrhagic stroke, which typically is due to that congenital formation of that aneurysm. So this is a saccular aneurysm, which looks like a little sac, and here it may also look like a berry, just by looking at the shape of that. So these are just the shape of the aneurysms from the prior slide that I was talking about. And then these are the arteriovenous malformation. Again, these are congenital, and it is when those tangles of arteries and veins form and they really don't have a capillary system, and eventually that will lead to a stroke. The next slide we have here is the coil procedure for cerebral aneurysm. Again, they insert a catheter. Through that catheter, they insert this coil, and they just fill that saccular aneurysm or that berry aneurysm with this coil in order to prevent blood from going into that area. Here we have the aneurysm clipping, which we have the saccular or berry aneurysm shape here. They put this clip over the neck of the aneurysm in order to prevent further blood from going in there and bursting that aneurysm. So now that we talked about the types of stroke, it's very important to know what is modifiable, what can we change, and what can we not change. So in this list here of some of the things that we have already gone over, we have hypertension, which hypertension affects 1 in 3 adults, and it is the most common cause of stroke. Is this something that we can modify? Absolutely, by taking medication, by living a healthier lifestyle, by having a healthier diet. So this is a modifiable risk factor. AFib is another one of the risk factors for stroke. Diet, um, specifically high cholesterol, is something that we can definitely modify. History of diabetes, 2 out of 3 people with diabetes will die from stroke or heart disease. Peripheral vascular disease. Smoking is another one that we can modify. Alcohol intake, so more than 2 drinks a day is not that good. So alcohol is another modifiable risk factor. Weight is something that we can modify by exercising. Level of fitness, another modifiable risk factor. So all from 1 through number 8 are all modifiable risk factors. When we get to number 9, age, something that we cannot modify. This is a non-modifiable risk factor. You are your age and you cannot change that. So the risk is going to increase after 55, where it doubles for every decade. Gender is something that we cannot modify. It's more common in men, but more women die from stroke. That's just a fact. Genetics is a non-modifiable risk factor. So your family history, everything that's being passed down to you from generation to generation, is a non-modifiable risk factor. And previous transient ischemic attacks is going to increase the chance of stroke by 24 to 40% within 5 years. So please be comfortable with the modifiable risk factors as well as the non-modifiable risk factors, what we can and can't change. So I'm just going to give you about a minute just to review this slide once again. I'm not going to read it again. So please make sure that you read it, that you know the signs and symptoms or the signs of a stroke, and that you know what to do when your patient is presenting with this. So as I mentioned this in a previous slide, a transient ischemic attack, sometimes referred to as a mini stroke, resolves within 24 hours. Longer signs and symptoms or neurological deficits that are present after 24 hours, that is considered a stroke. Okay, but anything that resolves within those 24 hours is known as a TIA. It's going to have the same signs and symptoms as a stroke. There will be no evidence of residual brain damage or neurological dysfunction, and more than 1/3 of all people who have had a TIA go on to have a stroke at some later time. And this is not just because they had a TIA, they're going to have a stroke, but it is kind of like a warning sign that if something doesn't change in their lifestyle, whether it be you don't quit smoking, you don't quit excessively drinking, you don't get your diabetes under control, you don't get your high blood pressure under control, you don't get any of those modifiable risk factors under control, then eventually you're going to have a stroke at some later time. And the TIA was kind of like a warning to you, to the patient, that something graver is coming. Okay, the risk of a stroke within 90 days of a TIA may be as high as 17%, with the greatest risk during that first week. So sometimes it is a precursor to a stroke, and then eventually that patient will go on to have a stroke at a later time, but sometimes maybe even that first week after that transient ischemic attack happened. It is very important to know the extent of the symptoms of a CVA, but in order for us to know the extent of the symptoms, we have to know the location of the area that is being occluded, therefore the area of the ischemia, the size of the ischemia, the area of the brain and its functions, and the availability of any collateral blood flow. Presenting symptoms may also really depend on the rapidity of the occlusion of a blood vessel, because slow occlusions may allow collateral vessels, meaning the vessels that are around it, to take over, whereas occlusions that are really, really fast will not allow for that to happen. So just know that your brain has very high energy requirements and very little metabolic reserves. So it requires that continuous, that rich blood flow to deliver that oxygen and glucose to the tissues. So it's a very powerful tool, but it depends on that continuous blood flow. Therefore, ischemia is going to affect it very, very highly. Also, please note that not every CVA is going to present in the same manner, because it all depends on that location, that size, the area, the functions, and how much blood flow is surrounding that area that's being affected. That can help. At this point in the lecture, I want to make sure that you are comfortable with some of the items that we have covered. And you need to ask yourself these questions. And if you are able to successfully answer these questions, then we are in the right direction. We're moving in the right direction with the CVA lecture and the content. So if you're able to answer, what is FAST? What is the difference between a CVA and a TIA? What are the risk factors of a CVA? Why is it important to call 911? What are the two types of strokes? What are the three medical interventions for an ischemic stroke? What are the three types of hemorrhagic strokes and how are they treated? What type of stroke increases intracranial pressure? What is the most common types of CVA? And lastly, which developmental posture or position increases intracranial pressure? So if you're able to answer these questions, you have been paying attention and you are able to answer some information regarding the last 21 slides or 20 slides that I covered. All right, guys, so this slide is blood flow to the brain. If you turn on page 598 of your O'Sullivan book, figure 15.1 will be the cerebral circulation, which includes the circle of Willis, which is what you see here. We have the anterior cerebral artery, we have the middle cerebral artery, and we have the posterior cerebral artery, which are pretty much the main ones as far as occlusions that we're going to be discussing. We are going to be talking about several other ones as well, but these are the main three that we're going to be talking about. So please get very comfortable with the circle of Willis and where each of these arteries are going to be supplying. All right, guys, so this slide at the top, the very top of the slide, it says to review pages 599 to 601. Extremely important, and I suggest that you look at these tables. What these tables are giving you is what are the clinical manifestations when my patient presents with an anterior cerebral artery syndrome or stroke. How is my patient going to present? How does my patient present with a middle cerebral artery stroke versus a posterior cerebral artery stroke or syndrome? So make sure that you review tables 15.2, 15.3, and 15.4 on those pages on the slide. So I'm going to talk a little bit about where do these arteries kind of branch off from, as well as what do they supply, because it is important to know what they supply in order for us to know what is going to be affected functionally with our patients and physiologically as well. So the anterior cerebral artery branches off of that internal carotid. It supplies the medial aspect of the cerebral hemisphere, so that includes the frontal and the parietal lobes, as well as subcortical structures, including the basal ganglia. The middle cerebral artery also branches off of that internal carotid artery, and it supplies the entire aspect of the lateral aspect of the cerebral hemisphere and the subcortical structures, including the internal capsule, the corona radiata, the globus pallidus, the caudate, and the putamen. The posterior cerebral artery branches off of the basilar artery, and that supplies the occipital lobe and the medial and inferior temporal lobe. It also supplies the upper brainstem, the midbrain, the posterior diencephalon, including most of the thalamus. So now before we move on and kind of talk about some of the clinical manifestations, it is very important for us to review the lobes of the brain and what each part of the brain is responsible for. So we start with the frontal lobe. Frontal lobe is the primary motor cortex. If you recall the precentral gyrus, it is responsible for voluntary movements on the contralateral side of the body. Okay, also it is where Broca's area is, and it is a motor component of speech, this area. So if Broca's area is affected, then you should know that the patient will have difficulty speaking with speech. It is also responsible for cognition, for judgment, for attention, for abstract thinking, and emotional control. It would be a very good idea to make yourself a chart of what is supplied by which artery and what the responsibility of each of these lobes is, so that you can kind of put two and two together and know how your patient will present based off of the syndrome that they present with. Moving on to the parietal lobe. This is the primary sensory cortex, which is the postcentral gyrus. It integrates sensation from the contralateral side of the body. It's responsible also for short-term memory. It's responsible for the perception of touch, proprioception, pain, and temperature sensations. So that is your parietal lobe. Your temporal lobe is where the primary auditory cortex is. It receives auditory information. It is also the associative auditory cortex, which processes that auditory information. So you receive that auditory information, and then the temporal lobe is also responsible for processing that auditory information. It is also where Wernicke's area is. So this is where your patient, where you have an intact Wernicke's area, therefore you're going to comprehend everything that is being said to you. If a patient has a stroke that is affecting this area, they're not going to understand what you are trying to tell them. So think about how this is going to be difficult for that patient to perform a transfer, for that patient to perform just simply getting out of bed when you're telling them to do it. So we have to keep in mind what areas are where so that we know what is going to be affected and how that is going to affect our treatment and our patient's progress in rehabilitation. This area is also responsible for long-term memory as well as visual perception. It is the primary visual cortex which receives that visual information. So that is your temporal lobe. Your occipital lobe is where the visual association cortex is housed, and this is now in charge of processing the visual information. So if we go back one slide, if I were to go back one slide, then you can tell that the the temporal lobe was the one that received that visual information. But now the occipital lobe is responsible for, after that temporal lobe receives it, now the occipital lobe is supposed to process it and apply meaning to what you are seeing or what the patient is seeing. And the next one is the cerebellum. The cerebellum, as you all should know by now, is responsible for voluntary movements, for maintaining posture, for maintaining appropriate balance, maintaining proper coordination, and proper walking. So if you have a patient that has a stroke or a CVA that is affecting the cerebellum, then definitely that patient is going to present with impairments in all of these responsibilities that the cerebellum is helping with. So they're going to have issues with posture, they're going to have issues with balance, coordination, they're going to have an ataxic gait. So just so that you can kind of foresee what is coming, and when we talk about the clinical manifestations of a patient post-stroke. So the final one we're going to discuss is the brainstem, which consists of the midbrain, the pons, the medulla oblongata. So the brainstem controls the flow of messages between your brain and the rest of your body. So very, very important. Also, it controls basic body functions such as breathing, heart rate, swallowing, the control of blood pressure, consciousness, and whether one is awake or asleep, or awake or very sleepy. So just by looking at those functions, these are very, very critical functions, basic but critical functions for our body to function. I can't say it any other way. So patients with this type of CVA will most likely die due to the critical areas that are being affected here. So very, very important to know that regarding the brainstem CVA. All right, so now we're going to talk about each one of the vascular syndromes. It is used in the same way as saying stroke, in the same way as saying CVA. So we're just looking at the vascular syndrome that is happening at each artery. And when that syndrome happens, what is my patient going to look like? What is going to be involved? So in an anterior cerebral artery syndrome, it involves the frontal and the parietal lobes. There is greater contralateral involvement of the lower extremities than the upper extremities, and this is because the somatotopic organization of the medial aspect of the cortex includes that functional area for the lower extremities, which is why there's more involvement of the lower extremities than the upper extremities with an anterior cerebral artery stroke. There's going to be contralateral motor and sensory loss. Additional signs and symptoms really depends if the damage is on the right or on the left, but some general signs and symptoms are going to be incontinence, are going to be apraxia, aphasia, slowness, and lack of spontaneity. So it's going to be also an affection. It's going to be affected also on the frontal lobe, which is going to make for personality changes. So this person is going to be moody. They're going to cry easily. There can also be a return of a contralateral grasp reflex. If you recall from test and measures, when we covered the lecture on developmental reflexes, so the grasp reflex comes back, and also that sucking reflex, also known as the rooting reflex, so that patient is going to get those reflexes back due to this anterior cerebral artery syndrome. So just by going through all of the possible symptoms and signs and symptoms and what is involved and what is not, when you are performing a chart review for a patient and you see that that patient has an anterior cerebral artery syndrome, you can definitely know ahead of time what that patient is going to look like. Obviously, each stroke is going to be different patient per patient, depending on the factors that we talked about earlier, but you may be able to deduce just from looking at the diagnosis that this patient may have better arm control than lower extremity control, because this is how it presents and this is the area that is affected. The middle cerebral artery is the second of the two main branches of the internal carotid that we discussed earlier. So most clinical signs are contralateral hemiparesis and sensory loss of the face and the upper extremity, now more so than the lower extremities. So if you recall, the anterior cerebral artery was more loss of the lower extremities versus the upper extremity. Now this patient is going to be the opposite. It involves the frontal, the temporal, the parietal, as well as the basal ganglia. My patient is going to present with homonymous hemianopsia, which is a visual deficit, and that's as far as I'll tell you now, because I will be covering homonymous hemianopsia in a couple of slides later down this presentation. Please know, as it says at the top of the slide, that it is the most common site of occlusion. All right. There's also going to be contralateral sensory and motor loss, and other signs and symptoms typically depend on whether it's a right or a left CVA. For right CVAs, usually there is unilateral neglect, so that patient is just going to neglect or ignore the side that is affected. Therefore, as therapists, we have to make sure that we talk on that side to try to get that patient to turn to that side and not neglect it as much. Another thing that may be present is going to be anosognosia. So anosognosia is a perceptual impairment that may include denial, they're in neglect, and they are they are not aware, they're lacking awareness of the presence of the disability that they have due to this stroke. So that is what anosognosia means. Apraxia. Apraxia is going to be that inability to perform purposeful movement. So the patients may have that capacity to do the motion, but they are not able to kind of put the steps together to achieve that movement. So that is apraxia. We also have on the left, if it's a left CVA, typically aphasia is present. So aphasia is basically an acquired communication disorder. It is caused obviously by that ischemia, by brain damage, and it is an impairment of language comprehension, being able to produce language and use symbols to communicate ideas. So it breaks down into two types of aphasia. So we have Broca's aphasia, and it just depends on the area that is affected. Broca's, that patient is going to have difficulty expressing what they're wanting to say. So the patients know what they want to say, but they're unable to form the words, they're unable to put those words together, and obviously that is going to make them frustrated because they're not able to articulate what they want to say to the therapist or to their family members or to the nurse. So it's very frustrating to them. Then Wernicke's aphasia with the W, we always correlate that to what? So Wernicke's is receptive aphasia, meaning that the patient is not understanding what you are trying to tell them. So always try to remember it with the W. Wernicke's meaning what. So you say something to the patient and the patient is unable to understand what you're trying to tell them. And this is due to that brain damage. The next vascular syndrome we have is internal carotid syndrome. Due to the branching of that internal carotid, both the middle and the anterior arteries are involved. So this is a very, very serious syndrome, a very serious stroke that includes both of the both of the arteries that we talked about in the prior two slides. So just by knowing that, all of those signs and symptoms that we talked about are going to be involved in this type of stroke or in this type of syndrome. So this generally is going to lead to a coma or even death. And the reason why is because there is when occlusion happens in this artery, it typically produces a massive infarct in that region of the brain supplied by the middle cerebral artery. So if there's no collateral circulation from that circle of Willis getting through that area, then the anterior cerebral artery is also going to be affected, which will give you this massive, extensive infarct. Okay, then we move on to posterior cerebral artery syndrome. And in this one, it involves the occipital, the temporal, the thalamus, and the midbrain. Very important to know what all of these are responsible for, just as in any of the syndromes that we've been discussing. But there's going to be contralateral sensory and motor deficits. There's going to be thalamic pain syndrome, also known as central post-stroke syndrome. And just by knowing that the thalamus is responsible for regulating pain perception, temperature perception, uh, touch. So, with knowing that this patient's thalamus is affected, therefore, they're going to have an increase response to any type of stimulus. So you can be working in the rehab gym with a patient and you're doing passive range of motion, and the patient that is suffering from this thalamic pain syndrome or central post-stroke syndrome is going to scream in pain because they perceive that you are burning or stabbing, and that's the type of pain that they're going to be perceiving because of this of the thalamus being affected. They're going to have potential vision problems. One of the ones that may be present may be homonymous hemianopsia, which we're going to talk about later on, and I've been saying. They may have visual agnosia, which is that the patient is not able to recognize things. This is not a visual problem. They are able to see, but they are not able to recognize things. Prosopagnosia, the patient may not be able to recognize the faces of familiar people. It may be their family members, it may be somebody famous on TV that they knew from before the stroke, so they're just not able to recognize familiar faces. Homonymous hemianopsia, I've talked about already, and we're going to be talking about it later on. As of now, just know that it is loss of the visual field. And then we have cortical blindness, which is blindness due to damage of the occipital cortex. As you see, number 1 here states that it involves the occipital lobe as well. All right, then we move on to vertebrobasilar artery syndrome. And vertebral artery syndrome is broken down and depends on what vessel is being affected. So it can involve the cerebellum, it can involve the medulla oblongata, and the pons as well. So if it is complete occlusion at the basilar artery, this is going to be the worst of all of them because it is a complete occlusion at that basilar artery that you see in the picture to the right. So this complete occlusion may lead to tetraplegia, which is also known as quadriplegia, where all four limbs and the trunk are paralyzed. It may lead to a coma, it may lead to death, or it may lead to locked-in syndrome. This occurs with a thrombosis and bilateral infarction of the ventral pons. So just to give you an idea of what locked-in syndrome is, it is a very catastrophic event. It is very sad for our patients with this. The patients are going to develop acute hemiparesis very, very rapidly, and then it progresses to tetraplegia or quadriplegia. All right. The patient is going to progress to not being able to speak after a period of dysarthria. And then they're going to progress to, not being able to speak. After that, they will have their consciousness and sensation preserved. So the patient pretty much is locked in their body. They're not able to move. They're not able to speak, but they will be able to be alert and oriented. Just they cannot speak. They are locked within their body. Also, there is going to be no horizontal eye movements, or horizontal eye movements may be impaired, but vertical eye movements and blinking uh, will remain intact in these patients. So this is how we communicate with patients that have locked-in syndrome. It has to be established through their vision. They have to blink once or blink twice for no. So it's a very sad condition. And according to the O'Sullivan book, mortality rates are very high. So 59% of those patients are, that's the mortality rate for patients with locked-in syndrome. Those patients who do survive this are very, very severely impaired. Okay, then we move on. If the occlusion is going to be at the cerebellar level, then that patient is going to present with ataxia, which ataxia is the lack of coordination. That patient is going to have balance issues. That patient is going to have coordination issues, postural instability, difficulty with that. They're going to have hypotonia. So just make sure that you are comfortable with all of the assessments for coordination that we went over during test and measurements. If the involvement is at the brainstem, you want to make sure that you review the cranial nerves, as there are many signs and symptoms based upon upon the loss of each of these cranial nerves. So just to give you some examples of a patient that has vertebral basilar artery syndrome that is affecting the brainstem, the patient may present with dysphagia, which is difficulty swallowing, diplopia, which is double vision, or dysarthria, which is difficulty with articulating sounds, putting those movements together in order to articulate sound. Also, paralysis is very common. It can be unilateral or it can be bilateral. All right, guys, so now since we have discussed all of the syndromes, we're going to talk about some common direct impairments of patients with cerebrovascular accidents. So there are 10, so please make sure that you are comfortable with these 10 common direct impairments. The first impairment is that impairment of somatosensory deficits, and you can refer to page 667 in your book, but these are deficits in somatic sensation that are touch, temperature, pain, proprioception. This can be a loss or impairments of those sensations. So superficial, it can be deep, or cortical sensations. If you recall those three very important categories that we discussed in detail in test and measurements. This all depends on the lesion and obviously the area and the extent of the ischemia that is dependent upon how much of a deficit you're going to see. The second one is pain. So we talked about thalamic pain syndrome, but there may be other types of pain due to that hemiparesis or that hemiplegia. That patient may have pain on their shoulder. So pain is a very common impairment seen in patients with cerebrovascular accidents. Visual deficits, and this is where we're going to cover homonymous hemianopsia. Visual deficits are generally present with middle cerebral artery, posterior cerebral artery, or a brainstem CVA. So the first one that we're going to be talking about is homonymous hemianopsia. And please see other visual deficits under the posterior cerebral artery syndrome as well as the brainstem. But the one that we will be focusing on is homonymous hemianopsia. All right, guys, so now we're going to finally talk about what homonymous hemianopsia is. And simply put, because it is a little bit complicated, it is loss of vision in the contralateral half of the visual field. So I'm going to give you an example with a right CVA, and then I'll give you an example with a left CVA. So what the patient loses is their visual field, half of their visual field, dependent upon if it's a right CVA or a left CVA. So in your patient should see this right here. So they're only going to see half of the visual field. It's going to be either a loss of the nasal field of one eye and the temporal field of the other eye. So here, letter C is where we're looking at homonymous hemianopsia. And let's say that this is obviously the left eye. This is your right eye. Your eyes are divided or controlled, or the vision is provided by half of one brain, half of the brain, and then half of the brain. The visual field is cut in the middle. All right, so let's say that my patient has a right CVA, meaning that the left side is going to be affected because we name the CVAs based upon where the area of infarct is in the brain, not in the body. So a right CVA means that the left visual field is going to be affected. It's going to be gone due to that CVA. So let's start with the right eye. With the right eye that you see here, since it was a right CVA, the left part of the right eye is going to be gone. That patient is not going to be able to see through this part right here. This is the nasal field of the right eye is going to be occluded. It's going to be gone. That patient is only going to be seeing through this part right here. Now let's go to the left eye. Still the same right CVA. Now the left part of the visual field of the left eye is going to be occluded. They're not going to be able to see. So this means that this area here, because this is the temporal field of the left eye, is going to be gone. That patient is not going to be able to see. Now the patient only has the nasal field of the left eye and the temporal field of the right eye, meaning that the patient had a right CVA, so both left sides of each eye are going to be gone. That patient is not going to be able to see. Now let's use this one as another example. Now my patient has a left CVA. Patient has a left CVA, so let's use this one down here. This is my right eye. This is my left eye. I'm going to cut the visual field into two because they're controlled by the two sides of the brain. My patient has a left CVA. Okay, so this is the second example that I'm giving you. Now, I'm going to go to the right eye first. The left part of the brain controls the right part of the eye, meaning that the temporal side of the visual field is going to be gone. The patient's not going to be able to see here. Now, that same left CVA, now we're going to the left eye, is also going to control the right side of the visual field, which happens to be the nasal side. So right here is going to be gone. So that patient is only going to be able to see through the left temporal on the left eye and the left nasal on the right eye. So that is homonymous hemianopsia. We have just 2 more slides, I believe, to cover. On this slide, you see how the view of Paris is for someone with homonymous hemianopsia and the view of Paris for someone with normal vision. So you see how it can be very, it's a very big visual deficit because my patient, let's say my patient has homonymous hemianopsia and you're seeing them in the rehab gym and you're just coming into their room and they have a tray of food in front of them and you see that they only finished half of the food, and it is because obviously that they're not able to see the other side of the tray, so they're not going to be able to finish their food because they have that vision loss due to this homonymous hemianopsia. So it's very important to tell that patient to scan the room, to scan everything to make sure that they don't miss anything on their tray. This one right here, if you wanted to give me an example of what type of CVA the patient at the top diagram has, if you said that the patient has right homonymous hemianopsia or a right CVA, you are correct, because as you can see, the left side of the visual field of each eye is compromised. Therefore, the side where the CVA occurred is going to be on the right. This is just another example of where in the areas where the areas are that are being affected. So number 1 would be the optic nerve, and it would obviously be blindness of the right eye. Number 2 is the optic chiasm, which is going to be bitemporal hemianopsia. So both temples are going to be affected. Then we have number 3, which is the optic tract. That is the one that we are focusing on. So I please just need you to know, I need you to know the left homonymous hemianopsia. And where that is happening is in number 3, which is the optic tract. So this is the area that is being affected during the CVA that is causing this visual deficit in our patient. Everything else is just something nice to know, but I will not test you on it. So just make sure that you know not left, but just know homonymous hemianopsia and what it is and how you can differentiate which areas of the visual field are being affected. Alright guys, so continuing on with the direct impairments from a CVA, we have motor deficits and Brunstrom stages. There are 6 stages of motor deficits. And Brunstrom is the name of a clinician who studied a lot of patients with cerebrovascular accidents as well as other conditions, and he kind of studied of how the patient was affected and how they will get better. So he started looking at the patient from beginning towards the end, and he came up with these 6 stages. The book on page 623 now calls it the stages of motor recovery. They still follow the same 6 stages as Brunstrom, but now they are called the stages of motor recovery. So stage 1 is that stage of hemiflaccidity. So at this stage, there's recovery from hemiplegia that occurs in a pretty much stereotyped sequence of events that begins with that period of flaccidity that you see there on the slide, and there are really no movements of the limbs that can be elicited during this stage. Stage 2, as recovery begins, hemispasticity begins with associated increased deep tendon reflexes. There may be some clonus, some class night phenomenon, and there may be a positive Babinski sign. At this stage, recovery begins and the limb starts to create these basic limb synergies. Right, so there may be muscle synergy patterns that start to appear. There may be associated reactions, so the tonic lumbar reflex, Suk's phenomenon, Ramistes phenomenon, and homolateral limb synkinesis, which I'm going to be describing in the next slide. Other reflexes that may be present during stage 2 are the ATNR reflex, which is the one where you are turning the head of the baby in one direction and the arm of where the baby's face or the individual's face is facing towards is going to be extended, while the other arm on the skull side is going to be flexed, kind of like the bow and arrow position. Okay, so these are the associated reactions that are usually present during stage 2 of the stages of motor recovery, also known as the Brunstrom stages. So homolateral limb synkinesis is a mutual dependency between hemiplegic limbs, meaning if the upper extremity flexes, then the lower extremity is going to flex as well. So if I ask my patient with a CVA to lift their leg, they sometimes will lift their arm as well, will flex their elbow as well. It's just a associated reaction, which is an abnormal reflex that comes along with that hemiplegia or that hemiparesis. Suk's phenomenon is bringing the involved shoulder into 90 degrees of flexion. The elbow extended is going to cause massive or mass extension and abduction of the digits. Again, just an abnormal reflex that is associated with this hemiplegia or hemiparesis. The third one being Ramistes phenomenon. This will be resisted abduction or adduction of the uninvolved hip, or the shoulder will cause either abduction or adduction on the involved side. So a lot of the times these associated reactions we can use to try to overflow, to try to irradiate into that affected side by using the affected side. So let's say I was trying to get shoulder abduction on the affected side, I would resist shoulder abduction on the unaffected side to see if I can get some response on that affected side. So sometimes we can use these type of associated reactions to our advantage. Then we also have the tonic lumbar reflex, which is thoracolumbar rotation to the affected side. The upper extremity is going to be flexed, the lower extremity extended, and rotation to the unaffected side is going to be upper extremity extension and lower extremity flexion on the hemiparetic side. So this reflex is initiated by changing the position of the upper trunk with respect to the pelvis. So, just to review one more time, rotation of the trunk to the right is going to result in flexion of the right upper extremity and extension of the right lower extremity. And rotation of the trunk to the left is going to result in extension of the right upper extremity and flexion of the right lower extremity. Again, all of these are just abnormal responses to hemiplegia, hemiparesis after a CVA. Stage 3 of stages of motor recovery, also known as Brunstrom stages, spasticity continues and may increase in severity. The patient begins to gain minimal voluntary control over those muscle synergy patterns that start to form in stage 2. They may still have some of those reflexes as well as some of those associated reactions we just went over. And then in stage 4, spasticity and reflexes are declining now in severity, and the patient can now perform single plane movements outside of those muscle synergy patterns that you saw in stage 2 and 3. So please make sure that you know that this is not set in stone for every single patient, for every single CVA. This is just a general timeline that Brunstrom put together after reviewing several types of CVAs and neurological conditions. Continuing with the stages of motor recovery, we have stage 5, which spasticity continues to decrease. Patient can now complete complex movements outside muscle synergy patterns. And then stage 6, typically there is no spasticity, no muscle synergies, no reflexes, or any of those associated reactions that we talked about. And they may have some paresis, which paresis, just to review, is weakness. So number 5 in the direct impairments post-CVA is hemiparesis, or weakness on the affected side of the body. Number 6 is disturbances in postural control and balance. So the patients may tend to lean away from the involved side. There's going to be asymmetry. And just also know with this, how is this going to affect our treatments? Obviously, if my patient is non-symmetric, when we're doing gait training, when we're doing transfer training, when we're doing balance training, postural training, this is going to present a challenge to us. So there is an exception to this rule where you are going to come across patients that are considered pushers or that have pusher syndrome. And the patient that has pusher syndrome will use their stronger extremities to push towards that involved side, towards the hemiparetic side. So you have to, this presents even bigger of a challenge because when you're doing gait training with this patient or when you're transferring with this patient is going to use that unaffected limb to push with all their might in order to shift their weight over to the hemiparetic or the weaker side. So you just have to make sure that you work on a lot of postural awareness with this patient, a lot of maybe working in front of a mirror to get that patient to get back to midline as best as possible, because this is going to increase the risk of falls, especially when we're doing gait training, when we're doing transfer training, because we stand that patient up and they're immediately going to want to push to that involved side, therefore increasing the risk of falls, increasing the level of assistance that is required from us when we're doing gait training. So pusher syndrome is definitely something that we need to work on getting back into as much asymmetry as possible, given the extent of the deficits that the patient has, of course. Number 7 is dysphagia. Like I said earlier, dysphagia is that difficulty swallowing, and you have to be extremely, extremely careful when treating patients with CVA and any neurological condition that is affecting their ability to swallow and chew and eat properly. This happened to one of my students that I had a couple of years ago, where the patient was had dysphagia, and he was on a soft diet because he wasn't able to chew, and the student asked the patient, if they wanted some water, but the student did not check to see if that patient was on a special diet, whether the food was supposed to be pureed, whether the water was supposed to be thickened in order for the water to go down a little easier because of their lack of the ability to swallow. So you have to make sure that you review, when you're reviewing your chart, the diet the patient is on or any fluid restrictions the patient is on, because you can cause more harm to the patient when they're not allowed to drink regular water and they have to drink some type of thickened water or thickened juice. So you always should make sure that you review your chart properly. There also may be cognitive dysfunction in our patients. There may also be bowel and bladder issues, as well as seizures, is our last direct impairment post CVA. Going back a slide further, I just want to say a couple of things regarding dysphagia and the importance of making sure that you know what the patient is able to eat and drink post CVA. So the biggest problem here is aspiration. We don't want any food or any liquid or any saliva to go into the airway, because it occurs frequently with patients with dysphagia. This can lead to respiratory distress, it can lead to aspiration pneumonia, and if left untreated, it may even lead to death. All right, so you have to make sure that you check your patient's diet. With the cognitive dysfunction in the prior slide, there may be impairments in the patients being alert, in their attention, in their orientation, their memory. So the patient may be confused, may perseverate, or just continued repetition of different words. They may confabulate, which means to say inappropriate words or stories that are made up. For bowel and bladder, there may be disturbances in bladder function. Those are common in the acute phase, so there may be urinary incontinence. There may be bladder hyperreflexia or hyporeflexia, which we're going to be talking about a little bit more in spinal cord injury. This patient may need a toileting schedule, meaning that they have to be taken to the bathroom at certain times throughout the day in order to prevent any accidents from happening. And the final one was seizures. I just want to add regarding seizures that they do occur in a small percentage of patients, but are slightly more common in occlusive carotid disease rather than medial cerebral arteries. So these are just very life-threatening if they're not controlled. So the patient may be on medication. So another thing to check on your chart review is just to make sure that the patient does not have a history of seizures. A couple other things that I need you to make sure that you review. So additional information that I need you to review is those synergy patterns that I was talking about previously. If you look on page 624, you should be able to find some information. Please review that. Information on muscle strength is found on page 616 and 617, as well as common postural alignment deviations associated with stroke on page 618. Ipsilateral pushing, which I covered already, but if you want to read a little bit more, page 619 and 631, as well as some gait deviations that are commonly seen post-stroke, table 15.5. I will also be covering a small lecture on gait deviations after this lecture. Alright guys, so now that we have talked about the common impairments for patients that suffer a CVA. Now we're going to break it down into what happens if the damage is on the left hemisphere and what happens if the damage is on the right hemisphere. There are some differences that are commonly seen following stroke dependent upon which hemisphere of the brain is affected. If you look at page 607, table 15.6, make sure that you review that. It kind of gives you in one table what happens at the right hemisphere lesion and what happens with a left hemisphere lesion, which are the next couple of slides that I'm going to be talking about. So for left hemisphere CVA, the patient is going to present with speech and language disorders such as Wernicke's aphasia that we talked about, where the patient is unable to understand what you are telling them, hence the W in Wernicke. And then they also may present with Broca's aphasia. Broca's aphasia is going to be that flow of speech is going to be slow, very hesitant. Their vocabulary is limited. Speech production is very labored or lost. So just expressive aphasia. They have that difficulty of expressing themselves. And then Wernicke's is the difficulty in receiving the information. They're not able to understand. And then we have global aphasia. It's just severe, marked impairments in both the production of speech as well as the comprehension of speech. So if you can imagine, it's very difficult to communicate with these individuals. I actually had a patient this weekend where he had global aphasia and we had to just communicate using a lot of tactile cues, um, sometimes writing things on communication boards, but there has to be other ways for us to be able to communicate with this patient. And then another speech and language disorder would be dysarthria, and dysarthria is just a motor speech disorders caused by lesions in parts of the central or peripheral nervous system that mediate speech production. So it's very difficult for them to put everything together in order to produce um, quality speech. They also have motor programming deficits, generally in the frontal and or parietal lobe involvement. So this would look like their loss of the ability to execute or carry out skilled movement, despite them having the want and the desire to perform a motion. They're physically not, and they're physically maybe even able to, but they just do not have that ability to execute it. And that is where we get to apraxia. So, apraxia is once again the breakdown between concept. So, the patient may want to roll to one side to get out of bed, but they are not able to have that communication. There's a disconnect between the idea of that patient wanting to move on to their side and the physical motor execution of actually doing that task. So that is where the breakdown is when it comes to apraxia. All right, so picking up from the last slide, we left off with apraxia, and it's just the inability or the difficulty planning and executing purposeful movement. So there are two different types of apraxias. We have ideomotor apraxia and ideational apraxia. So ideomotor apraxia is a patient that does a movement that can occur automatically because it is a habitual task, but if you ask the patient to do that movement, they're not able to do it on command. A couple of examples of this: giving the patient telling the patient, handing them a spoon, and telling them to eat. They may not be able to do it on command, but if you just put the spoon right on the table and you put food right next to the spoon or the fork, then they are going to eat because it is a habitual task that they can perform. Another example, giving the patient a comb to brush their hair, and the patient will not be able to do this because you've told them to do this on command. Yet you give that same patient that comb, put it on their hand, and they may be able to automatically start brushing their hair because you are not giving them that command to do that task. They are just from memory, it is a habitual task for them, so therefore they're going to brush their hair. Ideational apraxia, on the other hand, the movement does not occur either automatically or on command. So you can give this patient a brush, you can ask them to brush their hair. They're not going to be able to do it. And if you give them the brush without saying anything, they're still not going to be able to do it. Another left CVA sign that happens is perceptual dysfunction. It generally happens when there's a lesion to the parietal lobe, and it also can be the temporal lobe as well. So one of the key signs is somatoagnosia, which is a lack of awareness of the body structure and the relationship of body parts to self. This basically just means that the patient is going to have a lack of awareness of the affected side. So they're not going to be able to be aware of that side. They're going to neglect it. They're just going to lose that awareness of that part of the body. Patients also will present with right and left discrimination as well, meaning that they will be unable to identify the right and the left side. Patients with a left hemisphere CVA will have also behavioral hemisphere differences. So this type of patient with a left CVA will be cautious, they will be hesitant, they will get anxious, they will require a lot of feedback from the therapist. They do know about their self deficits, they are very aware of all of their deficits, and they are realistic as to how the condition is going to progress because they are aware of the gravity of their deficits after this CVA. They are also a little bit disorganized and often have difficulty processing information in a sequential manner. So, all these things we have to take into consideration when treating these patients. And number 5, we have other direct impairments associated with a cerebrovascular accident. There are motor and other issues are on the right side since it is a left hemisphere involvement. So just some of the common impairments that we went over, there were 10 of them that I went over. Those will also be present on top of these that are clinically seen in a left hemisphere CVA. Now we move on to right hemisphere CVA, which is going to affect the left side of the body. If you have been following the lecture, obviously know that the affected side is going to be on the opposite side of the body. So for this person that just had a right hemisphere CVA, there's going to be perceptual dysfunction. Generally, the affected lobe is going to be the parietal and it can be the temporal lobe as well. The patient will present with somatosagnosia. So somatoagnosia is impairment of the body scheme. So just as I mentioned with the left hemisphere CVA, it is just a lack of awareness of their body structure and the relationship of the body parts that are affected to themselves or to others. There's also going to be right and left discrimination. The patient will have difficulty identifying right and left sides. There's going to be also unilateral neglect. So, with unilateral neglect, the patient cannot register or integrate stimulus or perceptions from one side of the body. So they are going to ignore the affected side of the body. They're just going to neglect it completely, which is why we have to work towards bringing awareness of the patient to that affected side. So it would be talking on the affected side, so the patient has to turn to that side so that we can work on bringing that neglect, that unilateral neglect, down. We also have anosognosia. So anosognosia is completely different from neglect because anosognosia is the denial of the presence of the involved side. So it's generally the upper extremity, but it can be the lower extremity. In that patient's perception, they do not accept that side. They think that that side is not there. And this is anosognosia. It is completely different from neglect. Neglect, it just means that they can't register, they don't look that way, they ignore that side. But anosognosia means that they are denying the presence of the left side because we're talking about a right hemisphere CVA. So they just do not even accept that side. With the right hemisphere CVA, there are also spatial relation syndromes, which are typically due to the parietal lobe being affected. So, figure ground discrimination, that patient cannot distinguish the background from objects of the same or similar color. Position in space, they don't understand. So this is where we remember from test and measures when we talked about kinesthesia and bringing the limb up, 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 down, 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 in, out, out, out. So they do not understand where the limb is in space, the position. There may also be vertical disorientation, so they cannot perceive that upright position. And topographical disorientation, the patient cannot remember the relationship between areas even after repetition. Therefore, they're going to get lost when traveling from one area to another. So, in the hospital, when the patient has this um, topographical disorientation, we work on this by taking them into different locations in the hospital. And as they progress and get better, hopefully, they're able to navigate from the rehab gym to their room, from the room to the elevator. This is how we kind of work on improving this one of these impairments, one of these commonly seen impairments following stroke on the right hemisphere. The final one here is depth and distance perception. So there may be an inaccurate judgment of direction, inaccurate judgment of distance and depth. So if you recall from test and measures, the testing that we did to check to see if my patient is coordinated enough to hypometria or hypermetria for the distance. So depth and distance perception is very, very affected with a right hemisphere CVA. For a right hemisphere CVA, we have the ipsilateral pushing or pusher syndrome that we talked about. So if you sit that patient up, that patient is going to lean and push towards the weaker side with the stronger side. They will try to resist any attempt to correct this if the therapist tries to push them to correct that vertical alignment. So it's something that we constantly have to continuously fix because obviously that is going to be a huge risk of falls for that patient when we do bed mobility in or sitting position, bring that patient into a sitting position When we stand that patient up to work on sit to stands, when we do gait training, they're going to try and push off of the assistive device on the strong side, and that's going to increase the risk of falls. So, very important that you get familiar with the term pusher syndrome, because when you start treating CVAs out there, you're going to be dealing with patients that are have pusher syndrome, and you have to be able to correct that and prevent that from happening and progressing too much. Number four is behavioral hemisphere differences. So this patient is going to be very quick. They're going to be impulsive. So you have to be careful with this patient, because they're just going to want to get up without you even telling them to get up, or without you even wanting to work on sit to stands, so because of the impulsivity. So they need constant reminders that they need to slow down. So safety is a major, major issue with patients with right hemisphere CVAs. They may even overestimate their abilities, so they say they don't need your help when they actually do. They think they are a supervision patient while they're in reality a mod assist or max assist patient. This patient also may be very emotional. The emotional lability is common, so there may be episodes of just bursting out crying, or the direct opposite, laughing uncontrollably, and then periods of depression and periods of irritability. This is due to those behavioral differences based off of the hemisphere on the right side being affected. Some secondary impairments after CVA include DVTs, pressure ulcers due to that immobilization, that sometimes the patients are bedbound due to being max total assist, even depending on how severe. Due to that immobilization, also contractures may happen. Due to that hemiparesis or that hemiplegia on the one side of the body, the shoulder may sublux. There is also a lot of shoulder pain, or reflex sympathetic dystrophy may be present due to that shoulder subluxation, because that shoulder is just kind of hanging down, pulling down, because of the hemiplegia and the hemiparesis. All of this is going to cause deconditioning in our patients, and obviously it's going to have uh, effects on their functional capabilities. So there may be, or there will be, some functional disabilities. Some of the websites that are good for our stroke patients are www.stroke.org, which is the National Stroke Association, and we have the American Stroke Association, strokeassociation.org. So these are just good references to give our patients, and for also us to find out anything that has been added or changed um, as far as CVAs. So these are some post-stroke assessment tests that are used after evaluation, or during evaluation, or during reassessment, or close to discharge, to see how the patient is doing and how they have progressed through their rehabilitation. So these are all in addition to range of motion being performed, MMT, balance assessments, sensation assessments, ADL assessments. So they may also use the modified Ashworth scale, which you should know what it is. We also have functional tests such as the Barthel Index, which measures the degree of assistance required by a patient on 10 items of mobility and self-care. We have the functional independence measure, or the quality indicators system, which basically gives us, lets us score how the patient is performing and how much assistance the patient is requiring for tasks such as sit to stand transfers, stand pivot, bed mobility, gait training, stair training, wheelchair mobility. So all of these are included in this functional independence measure, or the quality indicators, and us as the PTA that are treating the patient are supposed to give them a grade of how much assistance the patient is requiring from us. We also have balance and postural control items, which some of these should be very familiar to you. Most of them should be very familiar to you. We have the Berg Balance Scale, which is that 14 functional tasks commonly performed in everyday life, ranges from sitting or standing unsupported to movements, and the score ranges for the max score is 56 on the Berg Balance Scale. We also have the Fugel-Meyer assessment of motor recovery for stroke patients. This evaluates and measures recovery in post-stroke hemiplegic patients. It's one of the most widely used quantitative measures of motor impairment. We also have the postural assessment scale for stroke patients. We have the functional reach test, which you all should know what that is. We also have the performance-oriented mobility assessment, or the TENETI, which is a static and dynamic balance assessment. It also has a gait assessment, a separate gait assessment. Then we have the timed up and go test, which measures dynamic balance. It measures sit to stand and mobility as well. And just to go back to the postural assessment scale for stroke patients, that is just an examination of postural abilities in patients with acute stroke. So a lot of tests that can be used as either just to check to see how our patient is starting with their rehab, and then once again, usually measured at the midpoint of the rehabilitation and then right before discharge to see how much the patient has improved. Further talking about some tests and measures that you all should be familiar with are the 10-meter walk test, the 6-minute walk test. We also have the walkie-talkie test, and then we have some disability, very specific instruments. As I mentioned before, we had the Fugel-Meyer assessment of physical performance. We have National Institutes of Health Stroke Scale. We have the Stroke Rehabilitation Assessment of Movement, and we have the Motor Assessment Scale. So the Fugel-Meyer is just that evaluation and a measuring tool to see how much recovery there has been in post-stroke hemiplegic patients. The National Institutes of Health Stroke Scale measures the severity of the symptoms associated with cerebral infarcts. It is used as a quantitative measure of neurological deficit post-stroke. We have the STREAM, which is a stroke rehabilitation assessment of movement, which was designed for use by physical therapists to provide a quantitative evaluation of motor functioning for stroke patients. This was specifically designed to be easy to administer in a clinical setting. And then finally, the last one on that list is the motor assessment scale, and it just assesses everyday motor function in stroke patients. So a lot of different assessments that can be used, like I said in the prior slide. All right, guys, and these are my references. And please make sure that you are reviewing this lecture in its entirety, that you are reading the chapter, and that you come to class ready to answer questions I may have, or if you need further clarification on items that were just not clear throughout this presentation.